I'm really happy to introduce now the next speaker from RKI, Ole Wichmann. Ole is heading our immunization unit and is widely recognized for his work in infectious diseases epidemiology, vaccination policy, evidence-based public health decision-making, and his work has really substantially contributed to strengthening our immunization strategies and also translating scientific evidence to practical public health recommendations. And especially now, we have touched this at many occasions now in these talks, in these times marked by misinformation, polarization, declining institutional trust in many societies, the question of how public health authorities can communicate evidence and make transparent decisions is becoming ever more important, of course. So I'm really happy that Ole is contributing with building and maintaining trust in immunization programs through evidence-based decision-making.
Okay, thank you very much, Ute, for the kind introduction, and many thanks also to the organizers to invite me for delivering this presentation here. So I've been asked to talk about evidence-based decision-making and then trust and how this interrelates and what we can do to maintain trust. So I will briefly touch on immunization-related policy decision-making. Why is it different maybe, or why is it not always that easy? I will talk about trust in immunization programs and conditions for fair decision-making, policy advisory bodies, and I will mainly touch also on STIKO, which is the German National Immunization Technical Advisory Group. Many of you know this advisory body in Germany, but probably not all the processes and also the rationale behind. And then finally, I will close my presentation with some activities which we are also conducting in terms of coordinated partner support and NITEC capacity building. So starting, I think it's a little bit basic, but I wanted to bring everybody up to the same level. So there's different processes from licensure actually to recommendation. So there's first licensure by a regulatory authority. They look at a vaccine-specific safety, potency, and purity. So I will not touch on this. I will cover in my talk mainly the policy-making part. So it's a recommendation. So here the main question is how to make best use of the available vaccine in a given presentation. And here it's not only safety and effectiveness, but also local disease burden, population impact, broader public health benefits, cost effectiveness, but also aspects like equity, acceptability, feasibility. So these are some aspects I will touch on later. So vaccine introduction decision or policy-making decisions in the field of immunization, it's a decision that involves trade-offs between likely benefits and downsides, risk, both at individual and population level, and that's important to understand. So likely benefits are reduction in number of cases, hospitalization, death, and protection of unvaccinated persons, for example, by herd effects, decreased costs in the healthcare system. Likely downsides are adverse events following immunization. Population level effects can be also potentially negative, like shift in age distribution or serotype replacement, and of course program costs, because usually you need to pay for the vaccine, for the stuff, etc. So you need to weigh these different pros and cons. There are also challenges, so it's not always a very clear yes or no, and there are often various stakeholders or interest group involved. There's so often quite some political pressure from the medical societies, from the population to introduce a vaccine to be covered by health insurance in Germany. It's a very dynamic and complex vaccine market, so we have increasingly number of new vaccine products on the market, sometimes against new infectious diseases. Then you need to include it in your program, sometimes with different efficacy or safety profiles. Then you need to compare, should we use this one or that one? There are already busy vaccination schedules, so national programs are increasingly asked to prioritize or optimize, especially if funding is limited. Data availability, so several key aspects are only known after widespread use. So if there's a very new vaccine, you know some data you have from the licensure studies, but sometimes it's even better to wait a few years until first adopter countries generate already sufficient data. So the question is, how much evidence is needed? Shall we wait a little bit or shall we introduce it now? And there's often, or at least sometimes, also ethical conflicts in vaccine decision making. So especially when there's vaccine shortage, so should you prioritize groups when vaccination will prevent most illness or death, like prioritization in a pandemic that was I think all NITECs or all decision bodies were involved in these discussions, or fast emergency approvals where there is a balance between beneficence or non-maleficence. So this means that you do good, but avoid causing harm in ethical terms. But there's also global vaccine distribution, so national interest versus global justice. So if there's only a limited number of vaccines on the market, are you the country that buys all these vaccines for your population? Or if there's also a vaccine available, if there's a limited production for other countries? So all this requires actually a transparent evidence-based approach when developing vaccination recommendations. Why? First, it helps, of course, improve the quality of a recommendation. If it's standardized, evidence-based, then after 1 year, you don't come up with an idea, or maybe it was a bad decision, but based on this evidence from 1 year ago, that was correct. So you should go with the evidence. And it creates consistency across a decision, facilitates also critical appraisal and comparison with other recommendations. So if in one country you have recommended the vaccine in this way, and another differently, if both countries explain the rationale behind it, which data used, it actually makes it a little bit clearer why there are these differences. And now coming to trust, actually, so there's an increase in trust and confidence in the recommendation. First, if you base it on evidence, then this is perceived fairness and competence of the body who is recommending this. So this creates policy legitimacy. And if it's transparent, this process, it's also reduced perceptions of hidden agendas. So there's not a, maybe because there's these different interest groups, and trust increases also when institutions openly acknowledge uncertainty. And visible scientific rigor also creates perception of expertise. So I would like to come now to trust. What means trust? It's a little bit complex. There's actually an increasing number of studies and research being performed, but also sometimes a little bit different concepts. And here I put some definition from Heidi Larson from the UK on how she defines this. So trust becomes important when there's an implicit imbalance of power due to a high level of information asymmetry, where trusting individuals accept a vulnerable position in relation to a trusted party. So that's this information asymmetry. So in the context of vaccine decision-making, one chooses to trust another to help make a risk-benefit decision about which one has incomplete information. So a common definition then in the studies is that trust means the relationship between individuals or between individuals and the system in which one party accepts a vulnerable position, assuming the best interest and competence of the other in change of a reduction in decision complexity. So I think it's important to stress here the best interest and competence. So if there's a decision-making body which is showing incompetence, this doesn't increase trust. Or if there's a body which has own interests and not your interests of the affected person, this also doesn't increase trust. So in vaccine acceptance, this involves multiple levels of trust. So there's trust in the product, in the vaccine, there's trust in the provider, so healthcare provider, but also trust in the policymaker, so in the health system, government, public health research, but also those involved in approving or recommending the vaccine. So that's the basis here. So there's actually plenty of studies that show the relationship between trust and vaccination hesitancy or vaccination status. So I picked one studies from the COVID-19 pandemic, where there was a sample of 1,500 Canadians being surveyed. And here they looked at the trust, both. They tried to discriminate actually the trust in interpersonal trust, so trust within the family, friends, and classmates, and trust in institutions. So institutions, they ask here specifically on the federal government, local government, WHO, healthcare system, policy, police, or in scientists. So that was, they explicitly asking this study about their level of trust. And here they stratified then the trust in those who have been vaccinated against COVID and those who are unvaccinated against COVID. And you see that first in those who are vaccinated, they have an overall general higher trust level, both interpersonal, but also especially institutional trust. And those who are unvaccinated in the samples, significantly lower level of trust, especially in institutes. And so the researcher here from Canada, they looked what is the strongest relationship. Strongest relationship was here the distrust in scientists and in COVID-19 vaccination status. That was the strongest relationship, but also distrust in WHO and COVID-19 vaccination status. So these were the strongest relationships. You can maybe argue it's COVID-19, what is maybe a little bit special, but they also looked at general vaccine hesitancy, and it was roughly the same. But there are also studies actually across countries. There was one survey, I think, covering 120, 130 countries, and it was shown it was across the regions. So it's a global problem and not only Canadian or high-income country problem. So here the very clear relationship between trust and vaccination status. Of course, there are other factors, but this is definitely one factor that can explain vaccine refusal. I also pulled here another publication. It's a systematic review, very recent publication, and here it's also about trust or mistrust in health organizations. So the findings of this systematic review was actually that evidence-based policymaking is usually a necessary condition for trust, but often not a sufficient condition by itself. So evidence-based medicine, evidence is good, but you also need other things in order to create trust in the population, which means transparency was identified, fair procedures, I will come back to this later, stakeholder engagement, and communication quality. And they also identified processes where they fail to build trust, evidence-based processes, and if they fail, if the public is unaware of the processes, so it's clear you need to communicate how you develop recommendations and how so you're trustworthy. If institutions are already viewed as untrustworthy, then it's for you difficult to rebuild the trust. And if political actors undermine scientific advisory mechanisms. I think my colleague who will follow the next presentation will touch on this topic. So that's definitely clear that trust will fail. So overall, vaccine policymaking is usually based, and it's an important message here, it's on evidence-based criteria for vaccines, is effectiveness, safety, burden, cost effectiveness, but usually very implicit, but definitely ethical principles. So what values should guide vaccine decisions to promote health and well-being, avoid causing harm, protection of vulnerable populations. So these are ethical principles which guide policy making and vaccination. And but also, and I will touch on this now, it's procedural fairness. So how decisions should be made when stakeholders disagree about those values, because there can be disagreement about these values. So it's then the procedures should be transparent, justifiable, and appeals mechanism should be in place. So I will very briefly touch on a concept of, it's called setting limits fairly. It's developed a concept by Daniels and Sabin, and they argue because they say that reasonable people disagree about healthcare priorities. So legitimacy is resource allocation depends on fair decision-making processes. And this is captured by their framework, which is called accountability for reasonableness. so A4R. So this is one concept which is creates fair priority setting, is achieved through transparent, relevant, revisable, and enforceable processes rather than through agreement on a single allocation principle. So there are these four concepts they stress here. This framework is highly influential and widely discussed in public health, health policy, and health economics, but it's not universally accepted as sufficient on its own. So that's the reason why some research has expanded actually on this four criteria, and I picked here the framework by Wichmann and colleagues, and they have actually 7 conditions for fair decision making. And this is first the transparency, so decision processes should be transparent and public. Consistency, so application of the same principles across health interventions. Justification is that decisions should be based on relevant reasons or on data, on evidence. Participation, so populations affected by the public should be able to participate. Managing conflict of interest, so decisions should be organized so such to minimize any existing or manage remaining conflicts. Openness for revision. And regulation, so that means voluntary or legal regulation should guarantee that these conditions for fair decision processes are met. So these are is a framework, and I will come back to this later because I will look if STIKO, so our body, will meet these criteria. First, I would like to very briefly touch on this advisory bodies for immunization policy making. So it's important to understand, so it's not only that we have this in Germany, actually in almost all countries globally, there should be a national advisory group called NITEC, but there's at global level with WHO, the SAGE, which is the advisory group at WHO, which advises the Director General. So they develop global policy recommendations and strategies, monitor global processes. And then there's also at regional level, so in the WHO regions, there's regional technical advisory group on immunization. Also, they rather try to contextualize the recommendation from the global body. And important to understand, probably not all countries in the world have got sufficient capacities in their national advisory bodies. So they quite rely on the global level especially. And if you consider, I mean, if people are looking at, for example, the effectiveness or introduction of a new RSV vaccine, doesn't make sense that all countries do the same work. So it's actually done at global level by SAGE, and they look at the evidence, provide this evidence, and then countries, especially those with not so well equipped and less resources, they can use this this guidance for their own national decision making. Coming to the NITEC, so the national, so what is it? It's a body of national experts that provide technical scientific guidance to the government in immunization policy norms and practices, and a scientific advisory group. The NITEC should ideally be independent from government. So that's one of the, how it should be, but I can tell you it's not always the case. What should a NITEC do? Conduct the best possible review of scientific evidence, bring credibility through expertise, minimizing pressure from outside interest group, eliminating real or apparent personal conflict of interest, provide timely evidence-based advice. So this is the NITEC, how it should work, and the existence of a functional NITEC is also one of the global strategic priority indicators in the Immunization Agenda 2030. So there's a global agenda for immunization, and one of the strategic priority indicators is whether a country has a functional NITEC. What is functional? There are 6 indicators. If there's a legislative in place, terms of references are in the written form. There's at least 5 different areas of expertise in the core members, at least 1 meeting per year, circulation of the agenda, and mandatory disclosure of conflict of interest. Sounds rather basic, but it's not feasible to implement this in all countries. You see here that's a global overview, but the majority, or so more than 90%, has a NITEC in place, and most of these cases, they also meet these 6 criteria. They are important, however, they don't tell you everything. So what has been discussed in the NITEC community is also whether the resources, number of staff available in the secretariat supporting the NITEC is maybe also one of the indicator, because some NITECs, especially in low middle income countries, sometimes have only one person or even zero support. And also the question if these functions or this criteria are sufficient to be resilience when there's political actors, they try to intervene in these processes, and probably this is not sufficient. So I want to close here this section here on this publication that was published in the middle of 2025, very soon after there was the start of the crisis. And there was during a meeting of SAGE at global level, the discussion whether support for the global advisory body will be reduced given the pullout from funding from the US and other partners and the financial constraints at WHO. And there was a call from SAGE members and the regional advisors on the integrity of immunization decision-making. This must be upheld through robust evidence-based guidance. And they stress that this structure with SAGE, RITEX in the region and NITEX, they play a vital role in ensuring that vaccine policies are informed by scientific data. And here these key attributes are already touched on. And one of the key attributes are also support country decision-making in this evolving context. So that was a call that this core function of WHO should be maintained. So now I will talk about STIKO and how we implement evidence-based processes. So STIKO was established actually more than 50 years, so 72, so quite a long-standing body, and we have between 16 and 22 members. They are appointed by the Ministry of Health, and since 2001, it's this role and terms of references are in the German Protection Against Infection Act, at least the role. So it's embedded in regulation. Then the disciplines of members are quite a number of disciplines from pediatrics, epidemiology, but interesting also for you, we have a specialist on evidence medicine, of course, infectious disease modeling and communication. We have a conflict of interest procedure. I will touch on this later, and several ex officio or liaison members from the Ministry of Health, Regulatory Authority, federal states, the BIÖK on communication to the public, and GBA is in Germany, the Joint Federal Committee, which is relevant for the coverage of the immunization and covering the cost. We have an executive secretariat at RKI and closed meetings at least 3 times a year, and we have working groups with external experts. So some of you who know these processes like ACIP in the US or SAGE, so this is roughly similar. So actually we started to implement evidence-based processes around 20 years ago. So there was some kind of set questions to be addressed when developing vaccination recommendation with 5 categories, but it was more semi-systematic and no systematic approach, no evidence grading, no documentation on explaining the processes. So that was like 20 years ago, and in the meantime, there was, I would say, a quite important date with the implementation or recommendation of HPV vaccination, which was a little bit more complex, a new target group, but also the effects of the vaccine to be estimated in 15, 20, 25 years, because you prevent infection and with this cancer in the long run. And so the data that were available didn't show, of course, the outcome of cancer that can be prevented, but more the pre-cancer lesions and so on. So there was a lot of discussions, and probably one of the mistakes was there was not a really good accompanying communication activities. And then the next year, there was also an official statement of 13 public health experts criticizing STIKO, saying there's no evidence-based processes in place, but also the GBA, so our joint committee, they actually since then request to have really all the evidence on the paper. It's because they make the decision on the coverage in Germany, and so they want to understand and appraise the evidence which STIKO has been used. So we established in 2008 a working group on methods and have several revisions of the key questions. And then with funding actually of our Ministry of Health in 2010, 2011, we had 2 international meetings, procedure for developing evidence-based vaccination recommendation. And here we invited colleagues from WHO, from ACIP, from Canada, from several European countries. Of course, they were also thinking about what kind of frameworks or evidence-based methods you can apply to vaccines. So we decided to test the GREAT framework. I don't want to go into the detail, but it's a systematic and transparent approach in rating the certainty of evidence. So it's a high quality or low quality of evidence, and we also perform training of the secretariat staff and STIKO members. We developed then standard operating procedures, how to develop a vaccination recommendation. We called it like this because we had several virologists in our group, and they said methodology, okay, we always in the lab, we have SOPs. And then we said, okay, why not call it simply SOP also on how to develop a recommendation? And since 2012, we have this SOP. And later we also decided that was very much focused on systematic reviews, but recognizing that STIKO, like all other NITECs, they also look at population level. Modeling the vaccination impact at population level is very crucial. And also there was the question, shall we use health economic evaluations? That was not actually on the agenda, was not politically accepted in Germany. So we developed a methods paper for transmission modeling and health economic evaluation with an international expert, but then also national stakeholder meeting. And we decided to use also health and economic evaluation as one criteria, but not as a yes-no decision like in the UK with a specific threshold. And finally, we also developed or adapted an existing evidence to recommendation or decision tool, which also make more transparent the reasons when you come from the evidence to the recommendation. So content of the STIKO, I don't want to go into detail. It's a topic selection and several points here. And this is the evidence and aspects to be considered. It's a product safety efficacy through systematic reviews, look at local disease burden, then estimate the impact of immunization, disease reduction with mathematical modeling, and then estimate the number needed to vaccinate and cost of the outcome with health economic evaluations. And then there's also at the end preferences and values considering ethical aspects and health inequities, but also programmatic aspects. So these are roughly the aspects STIKO is discussing. And here I'm looking a little bit at the time. So STIKO applies the conditions for fair decision making. And I showed you this 7 concepts, and in my opinion, STIKO meets all of them. There's transparency, the publication of rational scientific background paper, use of an evidence to decision tool, consistency, we use a SOP, justification, so it's a scientific, the data we show, participation. So before deciding on the final recommendation, we have a draft, send it out to medical societies, to federal states, so they can comment, and open for revision. So revision is always possible, for example, with new evidence or arguments to be considered. And regulation, we have a legal regulation, terms of references in SOP. So these are the transparency in decision making. We have all these different things published. For example, the meeting minutes here, the conflict of interest of all the different members. And management of conflict of interest in a multi-step processes. So before actually somebody is becoming a STIKO member, they look at the potential conflict of interest. If it's too much, they will not be a member. And but if it's just a little bit for one vaccine, for example, can be become a member, but then be disclosed from this session specifically touching this one vaccine. So there's also management. So we not only ask for a conflict of interest, but if one person for a specific vaccine has a conflict, he or she will leave the room. Okay, so communication, we have traditional publications and digital, we have a STIKO app and information sheet. So if you have good recommendation, but don't communicate, nobody knows about it, then it's not sufficient. So I will close my presentation with only a couple of slides with coordinated partner support and NITEC capacity building. As you have seen, or I've hoped to stress out the processes, what we have in place, I think are of high quality, I would say. But there are many NITECs in many countries who don't have yet these processes in place. So there's a recognition of NITEC support globally. So there was a global vaccine action plan. They had also this as an indicator that presence of an independent NITEC. There was at the World Health Assembly in 2017, so they urged member states to demonstrate stronger leadership of national immunization programs based on independent evidence-based approaches. And in the World Health Assembly 2018, they also asked to contribute that NITECs contribute significantly building in-country ownership and credibility to immunization programs. So WHO is requested to strengthen NITECs. And I think we have touched already in this colloquium on the need now for more country self-reliance, which is at the center of many shifts. So the DG of WHO called this year in response of the funding cuts that WHO is supporting many countries to sustain essential health services and transition away from aid dependency towards self-reliance. And at SAGE meeting in March, they've also discussed what can be done. And they also discussed the growing need for countries to prioritize their immunization programs in the context of increasing funding constraints, limited predictability of funding, and expanding vaccine portfolios. So they need to decide, or countries, which one to include in the program. They call it the country-owned evidence-informed processes should be in place to maximize the health impact of national programs. So to pick the right vaccine, which you should prioritize, and SAGE emphasized the central role of NITECs and the importance of coordinated partner support and capacity building to support countries making these sometimes very difficult decisions. So in this respect, actually, we as RKI said, okay, of course, we will never replace CDC, but at least we can contribute a little bit to these processes. And we also, with WHO, building on many years of collaboration, we established here at RKI a WHO Collaborating Center for Evidence-Based Immunization Policy Making, with a terms of reference, improving capacities, providing sustainable resources to NITECs, mainly in the regions, so middle-income countries mainly. We have here a project funded by the Ministry of Health within GHPP program on strengthened technical capacities for evidence-based decision-making with colleagues from the Immunization Unit, but also the Center for International Health Protection, where we jointly work on these activities. And here, just to show you, this is one of the documents, so ready-to-use templates and guiding documents for countries to make it an adopted evidence to recommendation process here. Or, for example, we maintain a global register of systematic reviews, where we also look at the quality of the systematic review. This is publicly available for all NITECs. We also develop online learning materials and movies, how to use this systematic reviews for beginners and advanced users. So that's my summary. So trust in institutions, including those involved in recommending vaccine, play a key role in vaccine hesitancy and refusal. Evidence-based policy making is a necessary condition for trust, but often not sufficient condition by itself. So trust depends also on transparency, fair procedures, stakeholder engagement, and communication quality. Scientific advisory group, like at the global, regional, national level, have normative functions and play a vital role in ensuring that vaccine policies are informed by scientific data. Legal regulation, terms of reference, standard operating procedures with support of a well-resourced secretariat guarantee to some extent that conditions for fair decision processes are met to some extent, because I wanted to highlight that it's not a guarantee that you're completely protected, but it definitely helps to increase trust and the good work. And that coordinated partner support and NITEC capacity building is a tool to strengthen country-owned evidence-informed processes in times of global uncertainties. Thank you very much.
Many thanks, Ole, for these insights in our STIKO work and how it developed and how it maintains and keeps trust in the population of the population. Are there any questions from the audience or from the virtual setting? So to start off, then I have also a provocative question for you. So why, maybe you could provide some arguments, why should vaccine recommendations be done at the national, but not at the subnational and not at the international global level? Countries are very different, nations are different in terms of population and size. So what would your arguments be?
Good question. We didn't talk beforehand, so not really. So no, I mean, but as you have seen, there are these three levels. So there are actually, it's a global guidance by WHO. I mean, they pull together all the data, and I think it doesn't make sense that all the NITECs perform the same work. I mean, it doesn't make sense. We all have limited resources. So it's good to look at the data that are, I would call it context-free, like vaccine effectiveness, safety should be roughly the same in Germany like in Spain, or only a few aspects sometimes are really different in malnourished children, but usually the vaccine works roughly the same. So looking at the evidence jointly or by one trusted global body, I think that's makes completely sense. But actually then you need to look at the national level in order to maximize the country's health benefit, because there are sometimes different epidemiology, completely different health systems, there are different costs in the health system for the vaccine and so on. So definitely then you need to take into consideration all the country-specific aspects like cost effectiveness, ethical aspects. For example, there are some countries like in Denmark or Netherlands we had discussed, for them they only want to introduce a vaccine which prevents death. So they see a value more in really preventing the severe outcomes. So there are other countries who say, I'm more also want to prevent quality of life or increase quality of life with the herpes zoster vaccines, and I'm also want to pay for this. And exactly these are the values which are sometimes completely different, but also for the same reason, doesn't make sense really to compare vaccination schedules between countries and say, okay, we need to reduce the number of vaccines because in another country it's less. They're usually good context arguments why a country decided, and it's also a little bit country ownership. You know? That's the reason why I think collaboration, global or regional, yes, but decisions should be at the national level.
Okay, thank you. Vivian Bremer.
Thank you, Ole, for this really wonderful talk. When I discuss vaccines with some people around me, there's often the argument, well, vaccines are produced by pharmaceutical companies and they only want to have profit. And this is, my impression is this is undermining a lot of trust as well. So how can we deal with this argument?
I think definitely more communication on the process is relevant. I mean, what I've shown, especially the first slide, actually shows you how we deal with this. I mean, there's first very rigorous processes for licensure. So a vaccine doesn't fall just from the sky. They need to produce the data. They need to conduct studies with a good quality and transparent for the regulators. And the regulator look at this data about the studies, how they have been performed, and then they only grant licensure for the market. And then as a fourth hurdle, we call it, so there's purity, so the quality, the safety, effectiveness. And then there's bodies like the NITECs who again look at all this data and see if it's really worth and to introduce this vaccine in your own context. So of course, there's sometimes competing interests. Of course, a manufacturer would be interested to recommend or to have the vaccine roll out for everybody. But exactly for this purpose, we have the NITECs who look if there's the benefit to the population with this vaccine. But definitely, I would also argue, I mean, we need the manufacturers because they make this investment in research. And so it's actually, there should be a partnership, but always being critical and being evidence-based.
Thank you, Professor Schade.
Thank you, Dr. Wichmann. So my question is, are you aware of any patient representation in NITEX in other countries, or probably better said, lay person society representation, and other experiences? How does it work? And probably it's as well worth to think about it concerning the STIKO.
Good question. I mean, I'm not aware about too many NITECs. Usually they're closed meetings, so it's not open for public. I think ACIP was one of the few with the exemptions, so that also everybody who actually register and can participate. I mean, if you have a layperson who doesn't understand this process, it's rather difficult to carry this person within this NITEC as a member. Of course, you can always consider have as a liaison person to provide some opinion, but so no, I'm not aware how if other NITECs really work with laypersons and how this works. I mean, we always say when we get requests, okay, why don't you include a layperson in this decision-making process? Actually, with GBR, they have a layperson involved. But to be honest, I'm not sure how much they really be then involved in this when they look at our recommendations. No? But yeah. I mean, it's usually, I mean, for other guidance, there's often like affected people by the disease, you know. So, but here we deal with usually healthy people to be vaccinated. So then really the question, who would be a good representative of your lay or of your population? Who should this be? I mean, parents, or I don't know, people who know at least some evidence-based processes. So
we have two more questions in the room, and you look none in the chat. Then Lucas Moreira, and the last one would be in the back.
Okay, first of all, thank you not only for the nice overview, but for your work, which as a local public health authority, we very much appreciate. So thank you for your work again, for your excellent evidence-based work. A provocative question, which I always pose when we meet. Do you believe that Germany will have a vaccination register?
Oh, it's completely a different topic. We can probably discuss in length, but the question always, what is the functions of an immunization register? Usually there are two functions. First, it's on coverage, that you really have almost real-time knowledge about the uptake of a vaccine in your population, in different groups and age, location, and so on. This actually we have with our current system already in place. I would say it's based on health insurance coverage data. The only thing we need to now work on expanding this to other vaccine service providers. So it's at the moment only the ambulatory doctors. So we need to expand to pharmacies and so on. And definitely we also have a challenge that there's some time delay, but there are opportunities to do this in the near future. No? What it doesn't allow is to use it as a reminder system. So in some countries, especially in the Nordic countries, they use this systems as a reminder. But I would argue, why do we need a system that it's doing both? You know, we can have two systems in parallel. So actually there are reminder systems and there's good evidence that they work. They're able to increase coverage. So we've performed also some literature review and so on. So you actually can have this at the private practice level, so that physicians using reminder system of their own clients, the patient. Also, health insurance companies, they can actually also use such a system, and they have the data available, and it's also not a problem with data protection, some say, but other health insurance companies, they already do this. So they send out a letter to home of parents where there's a 9-year-old girl and remind of HPV vaccination. So it's possible. So that's what I mean. Do we really need a vaccination register in Germany, or if it's sufficient what we have? Because I mean, it's this what we have. It's already building on 20 years of data, and this data is available. So why should we not build on what is already available? Why do we need to create our own system with all the challenges of data protection? Who is doing this and getting all the data from the past 20, 30 years?
So the last question would go to Claire Bambra.
Thank you. Obviously, all of us here and in the public health community internationally really respect and trust the sort of work that your committee is doing, and we have similar committees in the UK. My question is more about, I can see how what we do, what you do, provides assurance to policymakers, to educated members of the public. But what about that sort of 30 to 40% that you showed that are vaccine hesitant, who probably largely are in low literacy groups? More evidence, I don't lots of experiences, even out with, look at something like Brexit. The pro-Europe side was all about evidence. The pro-Brexit side was all about emotion. And I think this is a challenging question. I don't have the answer, but I'd be interested to know, if you in Germany, how you're trying to reach out to those groups, because obviously this matters very much when we're thinking about things like measles, for example, right? Thanks.
Okay, very, very good question, and not easy to answer within a few sentences. But no, we're fully aware of this. I mean, of course, there are different actors in Germany, or stakeholders. So we are more at RKI communicating to the professional societies, professional levels. And we provide usually different products. So the one with all the evidence, but also what I have shown, like a 2-pager. So the very in short, the rationale behind and practical issues and so on. So we already tried to have the full package and to have it condensed and easy written, so even also lay people, when they visit our web pages, can read. Then we have our own separate institute, BIÖK, which are actually, they are in charge of communicating to the public. So they are actually also not member, but they're sitting in our NITEC meetings, and they should be already, while discussing, thinking how this evidence or the arguments what we are discussing should be translated in a way that can be communicated to lay people and maybe people with less health literacy. But definitely health literacy is also what we perform as RKI, also is now acceptance monitoring in Germany, when we see that health literacy definitely is one of the critical indicator that where you need to which is creating definitely challenges. No, I mean, what we also think, I mean, important also the healthcare provider as probably the main stakeholder translating our evidence or recommendation to the patients. So definitely for us, the healthcare worker is a crucial target group of our communication. So because many studies, what we have seen shows very clearly, so if there's a healthcare worker who is convinced that this vaccine works, that was this trust in the healthcare worker or healthcare provider, I mean, that's crucial. So he should be also one part of translating this more complex to the people with lower health literacy. But there also needs to be trust in our system and the healthcare provider.
Thank you very much. I think we stay with the topic trust. So